The topic today is to discuss a case of a patient with intracranial hypertension, and the presenter will be Marek Mirski. And Giuseppe Citerio will moderate this session. And my suggestion is we don't have a full room. Please come closer so we can interact better. Don't be shy. Please come closer to the speaker. No, nobody's moving. Marek, try to convince them.
Yeah, come on up. Also, this is an interactive session, so we will have some times where we're going to stop the presentation from our point of view to prompt you to think and ask questions perhaps. But also, if during the presentation anytime you have a question immediately, just raise your hand or just holler, and we'll get to it, okay? Because the point is for you to leave here better knowledgeable about management of TBI and ICP than when you came in. All right. What we usually like to do is start with a case presentation just to familiarize yourself that these are patients that you probably see off and on in your own clinical work. So consider a 39-year-old gentleman, roughly 80 kilos, healthy, enjoys climbing. That's the catchword here. Oops. So at roughly 20 minutes after 5 o'clock in the afternoon, he fell. It looks like he fell approximately 12 meters, and he was found unresponsive, and people there at the scene thought he might have had a cardiac arrest. They initiated CPR and, of course, called emergency, and helicopter system came in within 15 or so minutes, and they did not report a cardiac arrest. There was blood pressure. There were symptoms of a pneumothorax, scalp wound with active bleeding, some exposed displaced fractures of the right wrist, potential pelvic fracture. He was unresponsive and had a GCS of 3. And tellingly, he had also left anisocoria and otorrhagia. So his vital signs were as noted on the left: very low arterial blood pressure is measured by a cuff. Heart rate is 152. Saturation was 82% on 100% oxygen. And a fast study showed a left pneumothorax. Confirmed at the scene he was intubated, and a thoracotomy of chest tube was inserted on the left side. A pelvic binder was applied, and he was treated with TXA and crystalloids and splints for stabilization. Okay, stop.
We are outside of the hospital, Marek. So you presented the case, and I don't know if you can return back one slide. The severe cases with, let's say, extracranial injury because probably pneumothorax and other problems. He fall down. Do you have any concern at this stage before arriving in the hospital? The patient was anisocoric, I think. And before arriving in the hospital, we will discuss about ICP mainly in the hospital later on. But are you thinking to do something at this stage, apart from intubation, ventilation, and so on, targeting ICP? I'm asking to you because there is a colleague there saying yes. What's your opinion? The microphone is coming. So we'll try to be interactive, stopping, and you can stop us. We try to involve you. So this is the game.
So we'll try to reduce ICP by giving hypertonic solution like mannitol or saline, for example.
And which is the indication from your point of view? The anisocoria?
Yes.
And the coma?
Yeah, and the coma, exactly.
Okay.
And the mechanism of trauma.
Okay, we are outside the hospital. From the hospital, we can suspect high ICP, but the patient have a very low arterial pressure, if I remember well, was 40. Aren't you worried about the possible side effect of hypotension due to diuresis, due to the drugs we are using?
Yes, especially with mannitol. So we should also resuscitate the patient, give noradrenaline, keep high mean arterial pressure, and then give the hypertonic saline, maybe more safe than mannitol.
Okay, you are enrolled, you are on the helicopter now, so you are bringing the patient to the hospital. You give a hypertonic solution, and Marek is waiting the patient in the hospital and probably is giving you some information at the arrival.
Yes. I'd just like to throw in the fact that since it's a trauma patient, especially falling, that the anisocoria could be peripheral. could have maxillary facial fractures and has a problem with a sympathetic innervation to the eye. But that being said, we have a CT scan, so immediately we rush them in, and you actually do see a frontal pathology. So what we see here on the right, predominantly right-sided pathology, likely a fracture there, but certainly contusive area of injury with some blood within the space of the cerebral parenchyma. But I will also just add that there's no acute subdural hematoma or epidural hematoma, which would be probably the more rapid concerns for anisocoria in the head trauma patient who's in coma, because the edema issues are likely to occur subsequently, not in the acute 1 or 2 or 3 hours. And we don't see a large collection of any blood product as a subdural or epidural. And the ventricles are small, but he's fairly young, so they could be relatively normal for his age.
Which are your priority now? We have a patient that outside the hospital was hypotensive, comatose, anisocoric. They give hypertonic saline along with fluids, we say, because we want to increase the pressure. And the pressure, I think the arrival of the hospital will be managed. We say the pressure is higher than 110 millimeters of mercury, we can say. And what are you thinking to do now? Because the patient is still comatose, and we have to take some decision. Therapies, intervention, whatever you want. Lisa, please. Any idea? No. The Zurich group? Well, there. Please.
Maybe we can try to measure the intracranial pressure with the... It depends where you are in the world, but like in France, you can put like a peak, a little dispositive here that you can do in the ICU, or you can bring the patient to the operating theater and put a derivation. In
this kind of patient, we can't, in our setting, and probably in Marek's setting, we are thinking about inserting an ICP in this condition. So which are the things you are looking for before going in the OR? This is a trauma, could have some problems, systemic problems, along with arterial pressure. The Zurich group say coagulation. And so I think a wise suggestion at this stage is to take a look at the exam, if you have time to take a look at the exam, because the coagulation could be impaired in this condition. And so having an idea that the platelets are okay. We are not targeting at this setting 100 in our country, so we are allowing also having a lower number, let's say 60, 50 will be okay in this setting. And we are going to probably insert an ICP. Who is against inserting an ICP now? Who is not in favor? You are not in favor? Why? Please. Marek, is it okay, this interaction? Do you want?
Well,
okay.
Maybe we can, in the very early setting in the hospital, trying to achieve some goals for stabilizing the ICP. For example, we can use the ghost cap at the very early treatment. Then we can try to measure the ICP in the intracranial pressure in a non-invasive way. And of course, we have to reevaluate the tension pneumothorax that the patient got and some other injuries because of the high intensity trauma that the patient got. If the patient remains unresponsive, maybe we can go further in the algorithm of ICP treatment, going to tier 1 and 2. And in that point, we can insert the proof.
The question, you answered 2 questions. The first one is to insert or not insert the ICP. You are the only one inside this room against, and then we will comment on it, and then we will discuss. And the second point is to fix all the other extracranial parameters, and we fully agree. We can, let's say, give that all the other extracranial parameters, including coagulation, are, let's say, because Marek said we need to focus on ICP. So I will remove all the other confounders here. So we can say that pneumothorax got a drainage, we don't have hypoxia, we don't have a major problem outside the brain. But the problem here is why you want a at this stage, non planning an insertion on intracranial pressure now. The patient is very severe, GCS of 3.
It's categorized as a severe trauma, yeah.
He got a positive CT scan. We have an early contusion that could evolve. And I don't know why you want to wait, because the coagulation is okay, the patient is coming to the unit. I don't know which is the advantage to go waiting now.
I come from Latin America, and we always direct the therapies starting from non-invasive monitoring. As I saw, the CT maybe is a Marshall 1, and when we categorize the CT with Helsinki, Rotterdam, and Marshall, we decide if the patient must go to the OR for a ICP-proof placing. Otherwise, we can use the non-invasive way. We use optic nerve sheath diameter and Doppler. And if we have not good parameters and the patient is not going clinically well, then we go to the OR, but not at the very, very beginning state of the treatment.
Yeah, the problem here is that we discussed in another section a couple of half an hour ago. All the non-invasive methods have some pitfalls. So they are not precision is a problem of you can estimate if you are below or higher than 20 millimeters of mercury roughly, but you cannot measure ICP. And in this case, I think could be very useful to look at the trends, looking at what is happening to ICP along with arterial pressure, because we need to understand if the patient is able to have a normal autoregulation. This is a very severe case. And so my propension is similar to the other colleagues to go, at least in this setting, and we are not discussing this case in South America. I say in Europe, we insert a catheter, an invasive catheter in this setting, after fixing the extracranial problem, coagulation, pressure, pneumothorax, and so on. I don't know if someone else has any other comment, please. We try to be interactive, so you can comment whatever you want.
We have a severe...
Where are you from?
I'm from Portugal.
Portugal.
From Coimbra. We have a severe TBI.
Yeah.
And we have signs which are compatible with intracranial hypertension. Glasgow of 3, right pupil larger than left. So we have to think that this patient has intracranial hypertension. So we need a neurosurgeon and maybe a primary comprehensive craniectomy, because CT seems with edema, and maybe a pressure intracranial immediately.
Mm-hmm.
This is a discussion.
I think the reason why we want to insert a catheter is to understand if this mass lesion, because the mass lesion she was referring to, the Marshall score is a Marshall score of 2, because there is a lesion below 25 cc's. There is no, we don't see the system here, but there is no compression of the system, the ventricular system.
Agree.
So probably the patient will be operated later on, maybe a couple of days after. I don't know if I are going to do a decompression or not. I'm not sure whether I will be decompressor, but at this stage,
we need intracranial pressure.
I prefer, for being prudent, because also we are very early. In the first 6-12 hours, patient could develop contusion of the other side, could develop other hematoma. So let's say, in half an hour, 1 hour, the patient arrives from the lake to the hospital, and we have a CT scan that Marek showed you. And so at this stage, I don't ask a surgeon to operate the patient, as you suggested. But the idea of involving the surgeon since the beginning is crucial, because for these cases, surgery is a solution sometimes. And the insertion of the ICP, I don't know who is inserting the ICP device in your setting. In my setting, the neurosurgeon, the resident of neurosurgery are inserting the ICP. There is a lot of discussion of intensivists inserting ICP. How many intensivists here insert by themselves the ICP catheter? There is some trends in some countries. suggesting that the intensivist could insert an ICP. Could be done, but my suggestion when you insert an ICP, discuss with a surgeon, because when you have trouble, when you need to go to the OR, it's better to have a surgeon on the same side. And so work together. Why you are laughing? Because it happened in your center? Now, do you want to
Imagine how bad it can go if they don't know well.
No, it happens in some center, but I think it's a marker of bad communication between the two equipes. And I think the sign of bad communication is a wrong side in this setting, because half of the patient got surgery. And so if you call the surgeon 2 days after and say, I am in Portugal, I put an ICP, and I worked 2 days, and now you have to operate the patient, the answer will be a little bit, let's say I will not report the answer here. At the end, they have to operate the patient, but they are not happy. So we say, almost everyone except our colleague from another setting, applying the concept in your setting, because you say before going in the OR, in my setting, I do non-invasive monitoring, but in our setting, we say the patient got an ICP. And I don't know, I think that in the slide you have already the ICP inserted. No.
No, I didn't have it show
Okay.
yet.
Do you have another question? Do you want to provoke them in another way?
Well, I will just say that in sort of support of our, the woman there who made that nice statement about her practice, the placing of an ICP has not been level 1 studied appropriate. There is actually evidence in our neighbor to the south in Brazil that patients can be followed by serial CT scanning as a surrogate for looking at swelling, edema, and medically managing the patient, or even going to craniectomy, if you will, by following the scans serially and not with an invasive catheter. That being said, those patients were typically more stable in terms of their run. Here you have a patient who's actually going to the OR for other medical needs, such as potentially thoracotomy, maybe a laparotomy to examine, but a lot of things are happening in this context, and there's going to be fluid challenges, et cetera, done by anesthesia and so forth. If you have the option to put in a catheter to look at the actual number and trend it over time, I think most centers would probably support that. And whether you put in a bolt or a Camino catheter or a ventricular catheter, our preference in our system is if you can put a ventricular catheter, you put that in preferentially because you actually have a therapeutic modality attached to it by drainage, whereas a Camino just gives you a number. But anyway,
I think we reach a bare consensus. Please insert an ICP, Marek.
yes, I think in general most people would probably put one in if you had the opportunity. If you have a center that doesn't have one, a capability, and certainly in our institutions we like to get our neurosurgeons involved too. In the United States, it becomes a liability issue too. If you have some non-person who's pseudo-trained to put it in and you get into a big hematoma or something, patients' families don't like that. So having the specialist perform it is always best. Okay.
Sorry, I have a question.
Well,
Here, yeah.
Okay, perfect.
So we decided to insert the ICP monitor, and
Yes.
would you also insert now a cerebral oxygenation monitor, or if you had the option?
Well,
We have a discussion in the previous session with Pierre Bouzat, that was the last author of a trial on brain tissue oxygen published on The Lancet a couple of weeks ago. And the answer is at this stage, not in all the patient is suggesting to insert a catheter, because the evidence we have is not so strong. Guiding therapy with the Lancet neurology paper published recently. So, in my opinion, at this stage, we don't have any indication to insert nothing except the ICP.
that being said, we have a catheter placed, and this one's a drainage catheter, appears to be. And now, Giuseppe, you are getting into your...
No, I put this slide saying that we have different options now. We don't know how much is the ICP we see in a while, but the slide here is for saying to you that we don't have so much evidence today guiding you for selecting a threshold or an individualized threshold or a group of therapy. So what we did in Seattle, and is summarized in this slide, is that we tried to reduce the damage and rank the approaches starting from the less complicated by, let's say, side effect. For example, craniectomy will be the last stage, barbiturate will be the last stage, and so we start from sedation, osmotic, CPP therapy. But the suggestion for you is to return back in your center and think about the way you are treating the patient and start to standardize the patient. And so in this case, the patient did arrive in the unit, and the basic tier zero of managing ICP is making some good critical care. So patient is intubated, ventilated, with a normocapnia, with an arterial line in, with a central venous catheter, with an hemoglobin at least a 7. We had a patient with a severe damage, so probably we need to control also hemoglobin at this stage. So we are doing nothing else but treating the patient properly from a general intensive care point of view, control of temperature, sedation, and so on.
Which you just nicely listed as shown here.
What?
Well, this is your tier 1 right here.
Okay, no, we are 0 now.
Oh, it's 0.
Zero will be okay, so 0 will be done to everyone. I don't know if we have a tracing or an ICP. So let's say that the ICP now is around 18. What is your impression now? What are you thinking? Is a problem, is not a problem? It's the early phase. The patient did arrive. You can ask questions, how much is the CO2, how much is the arterial pressure, and so on. But 18 of ICP is worrisome for you, is a problem. Are you thinking to start treatment? Are you observing the patient? We didn't do anything because the 0 tier is light sedation and nothing else. Please.
Even though 18 is not the limit of the 22 that is established for needing to do some measurements, of course, if we have some other values to check, for example, the NIRS, we can see if there is some impairment of the oxygenation of the brain that we need to improve. And sometimes we need to do that by increasing the cerebral perfusion, and that can be done by increasing the mean arterial pressure or reducing the ICP. It depends.
So you are guiding your therapy at this stage on NIRS or some other information on oxygenation. I think is a quite extreme decision at this stage. Use NIRS in this stage for defining if ICP need to be treated or not. And I would like to look at the other parameter, for example, if a patient has a good or not good autoregulation, increasing a little bit the pressure, looking at other parameter. But at this stage, probably my first choice will be to increase a little bit sedation. If I say that stage 1 is a light sedation, I would like to start the sedation because a patient for sure will evolve looking at the first CT scan. So we are in the first hours. I will not give osmotic or other therapy. My suggestion at this stage is to increase sedation. I don't know if there is any other option, other suggestion. Yeah, please.
So let me, I'm sorry.
How is the morphology from the curve? Is it P1 higher than P2 and P3?
I didn't got your
The morphology of the waveform of the ICP.
Waveform. Oh, okay. So you were at the case of Fabio. You were at the presentation of Fabio. I would say to you that P2, but I give you a trick, is lower than P1 even if ICP is 18. And if you look at the previous CT scan, there were some problems in the CT scan, probably you didn't realize, there was some air. Probably the patient got a fistula, okay. CSF fistula, so the waveform doesn't respect physiology because the skull and the dura are not closed. So P2, in this case, if you lose CSF, doesn't go up when ICP goes up correctly, like in the normal patient. So I would say to you, for putting you in difficulties, that there is a fistula and the P2 is lower than P1.
So let me ask you, Giuseppe, why would you increase sedation?
Because I think...
he's a GCSO3, and we haven't mentioned anything about whether he's agitated. He could be just lying there. Would you absorb and sort of confound the neuroexam by sedating?
The neuroexam, I will test it later on, but the patient has a, let's say, a slight increased ICP. You can stay also at 18, but what we learn from the study we did with Leuven is that the time of exposure to a certain level, pathological level, is a problem, even 18. I don't use the fixed threshold 22 because 20, 22, the threshold lies between, let's say, 15, 18, and 25. So we need to adapt it. It's not a threshold, it's 10 millimeters of mercury, so it's a huge range. Sedation, reduce metabolism, reduce a little bit due to the coupling between metabolism and flow, reduce a little bit the cerebral blood flow. We have a contusion in the frontal lobe. Reducing where metabolism could be reduced, the blood flow is not dangerous at this stage. And I prefer to have 15 of ICP in this patient in the first day, even after fixing every of the other problem I have. But it's, let's say, an opinion. If you want to keep the patient 18, my suggestion is keep the patient to a slightly high, is not normal, ICP for a short period, not for a long period, not for 2 or 3 days, 18.
So obviously,
any comment, any request?
Do we have a transcranial Doppler and an electroencephalogram at this stage?
We didn't. The patient is sedated. We didn't do an EEG at this stage. There is no seizure at this stage, but he has sedation. He is sedated, and we increase sedation. And if you want to see the TCD, what are you looking in TCD? The waveform or?
Also the peak velocities.
The peak velocity. We can say that is.
The waveform.
So you are searching, like your colleague, other elements for starting a therapy. So
to understand the situation we are in, actually, before starting a therapy.
Okay, we can say that we don't do routinely the TCD in this setting for understanding if there is a compensation or not. We look primarily at P1 and P2 as has been referred, and I can say that this TCD is normal in this setting. So you will wait if the TCD is normal, P2 is lower than P1, you will wait for starting any therapy, or you stay. What do you want to do?
Well, we are at target now, actually, with the sedation.
Okay, we increase a little bit the sedation. Yeah. Okay, let's say the ICP is more controlled now. I think you have a slide with a tracing of ICP. I don't know if it's now or later on.
Are you concerned about non-convulsive seizures? Was the reason for the EEG, or are you just confirming that he's got delta waves?
Actually, to decrease the cerebral consumption of oxygen.
If he's overtly seizing.
Yeah.
Yeah. Okay. We too probably don't rush in and put an EEG on someone who comes in with fresh trauma, but it's something certainly to be considered. And my only other added comment is that if his ICP is 18 at this stage, it's going to go up, right? Right. This is pretty early in his trauma. Okay, tier 1.
We decide already to go to tier 1 because we increase sedation. And which is your target PCO2 in this setting for a patient like this? He got a pneumothorax, he got a drainage, probably had a pulmonary contusion. We didn't show you the CT scan, but he had a pulmonary contusion. So in your mind, which is the ventilator setting that we can propose to this patient? Because we increase the sedation. Marek said that ICP remain a little bit higher, let's say 16, 18. So do you want to move a CO2, or do you want to start an osmotic therapy because you don't want to do CO2 reduction? Do you want to reduce CO2 or not? Normal low, does it mean 35? 35. Okay. The group from Zurich, what does he say about hyperventilation? See or no? Yes or not? Okay. You approve the reduction of CO2. So we can move a little bit the CO2, and the mechanism is the reduction of cerebral blood flow we can produce. Do you think that we are causing damages reducing CO2 at this stage? Because there is a lot of warning about CO2. People is worried about reducing CO2. Who is against reducing CO2 a little bit? Nobody? Okay, there is a couple. Oh, Marek, there is a colleague there. Why you are worried?
Well, we decreasing the CO2. We also decrease the blood flow to the encephalo, to the brain at this state. We can actually.
Yeah, the problem, as demonstrated also by the group from Zurich, in a short case series on microdialysis, there are two problems. We are managing CO2, and we are thinking that changing the pH across the vessel because the CO2 pass through the capillary in the brain, we are producing a global reduction of cerebral blood flow. But there is another element, metabolism. If you have still a metabolism of the brain, you will produce locally CO2. And the CO2 you produce locally counteract in some area the reduction of the CO2 you are aiming to with the reduction of the CO2 with increasing the ventilator. And so I will suggest you to search, because you are young and you are smarter than me, to search a single model of animal model in which reducing CO2 till 10 millimeters of mercury, you are able to produce a damage in the animal. There is no literature, because metabolism rules. Metabolism brings flow. And coupling is coupling between metabolism and flow. So if you search all the animal models, if you search an animal model for bleeding, reducing the pressure, you will kill the animal. Reducing CO2, you will not be able to kill any animal. And so we are worried about the use of hyperventilation in this setting, because some studies, mainly from the Cambridge group, demonstrated that when you reduce acutely the CO2 locally, there are some areas in which the blood flow goes down. But metabolism is not checked in that area. And if you look at the imaging later on of this patient, there is no ischemic event there afterwards. And there is only one randomized controlled trauma dated, I think, 2002 by Marmaru and Muisala, in which he started to use hyperventilation in a small group of patients, because at that time no large randomized controlled trial were run, about 30 patients per group. And the group of patients that had experienced less ICP and survived better at 6 months, even if doesn't reach any statistical significance, are 30 patients, but there was a signal, was the patient with hyperventilation plus TAM, with bicarbonate, we tamponate the effect of the reduction of CO2. So if you study physiology, you don't find sign of a problem of reduction of CO2, but we are very worried about reducing CO2. But at this stage, I agree with most of you that would like to reduce a little bit CO2, because I don't see a major problem in it. Maybe Marek will say something different, because we don't have strong evidence on it, but I don't see the problem in reducing a little bit CO2. Okay, it's the time for the next speaker. So we didn't treat ICP properly because we stopped early, and she said that we are too long, and so we have to stop here. I'm sorry about that, but I think we have some discussion on a couple of topics, mainly ventilation, CO2, barbiturates didn't touch them, mannitol, osmotic therapy, and so on. Thank you, Marek. You said too many slides, short time. Thank you for your.
I don't have any problem with mild CO2 reduction, by the way. The only reason I would argue not to do it is it's temporary therapy in terms of reduction of ICP, and so we usually put that in our back pocket and use it when there's a real crisis, because we know it only lasts for a few hours. So if you have other ways to sort of manage the cerebral edema and ICP at that point, we'd go to those other therapies first. That's all. Thank you, though. Thanks for all your interaction.